big welcome to everyone for coming along to this week's Winter Spring webinar series on the topic of T-cell lymphoma. A very warm welcome to all of those in our LBC community of patients, families and supporters who have tuned in today. I hope you are nice and comfortable wherever you are in the country or maybe even overseas, and that you have a nice cup of tea, coffee or maybe your lunch ready to go. So my name's Natasha. I'm one of the support services coordinators for Leukemia and Blood Cancer New Zealand. I'd like to extend a huge welcome and a thank you to Dr Samar Issa, who is here with us today and who I will introduce shortly. Firstly, I'd just like to let everyone out there know how today's webinar will run. So shortly, the wonderful Samar will share with us her presentation, and you're all welcome to submit questions as we go in the Q&A section at the bottom of your screen. These will be answered at the end of the talk. So we'll be limited on how many questions we can answer at the end of this session. However, please note that any questions that aren't answered today will be either answered on our YouTube video or they'll be posted in the coming days on our Lymphoma Facebook page or in one of the talks to come. It's also worth noting that this talk is one of a series of talks about lymphoma. So specific questions about other lymphomas might be answered in the relevant talk. So Dr Samar Issa is a consultant haematologist and clinical head of the Lymphoma Service at Middlemore Hospital in Auckland. Dr Issa is an active member of a number of scientific groups, is the founding chair of the Lymphoma Network of New Zealand, and the founding clinical director of the Middlemore Tissue Bank. She has multiple research publications and is the primary investigator on several local and international lymphoma clinical trials. So, with a big warm welcome, I'd like to hand over the time to Samar for her presentation. Thank you, Samar.
Thank you, Natasha, for the introduction, and thank you for inviting me to give this talk to our patients on T-cell lymphoma. Thank you all for attending this webinar. In a previous talk, I presented the biology of lymphoma a few weeks ago, but I will touch again on the basics of what lymphocytes are and what lymphoma is prior to talk about T-cell lymphoma, which will be extremely helpful in helping us to understand what this lymphoma is and why it is important and how do we treat it. So what is a lymphocyte? A lymphocyte is a component of our white blood cells. As a matter of fact, it is the smallest white blood cell, and it is an important part of the immune system. It usually comprises 20 to 40% of all of our blood cells in the peripheral blood. And that's what it looks like, a big nucleus in the middle with the DNA and a bit of cytoplasm at the outside. All the lymphocytes, as a matter of fact, all of our blood cells are made inside of our bones in a place that's called the bone marrow. And these cells all arise from one mother cell, which then differentiate and become all of the rest of the blood cell components, whether it is white cells, red cells, or platelets, which are the small particles that protect us against the bleeding. And the bone marrow exists in the long bones as well as the flat bones. One of them is the pelvic bone. And if some of you had a bone marrow biopsy, this is where it is taken from to enable us to look at all of these blood cells and check on their well-being and also to determine the stage of the lymphoma. and whether the bone marrow is involved or not. So as I said, all of our blood cells arise from one mother cell that is present inside the bone marrow. It's called the stem cell. That stem cell gives rise either to the red cells, to the platelets, to the other white cells in the body, as well as to the lymphocytes, whether they are B cells or T cells or natural killer cells. So as I said, according to how they leave the bone marrow, when they leave the bone marrow, their surface markers and what they look like, we can divide the lymphocytes in our body into T cells, B cells, or NK cells, natural killer cells. Today, we will focus on the T lymphocytes. And how can we tell each lymphocyte from the other? We can look under the microscope and see what they look like. And we can also do specific tests, including cell marker studies, to look at the outside of these cells' antigens that usually tell us what cell we are dealing with. And so why it is important that we have T lymphocytes, B lymphocytes, and natural killer cells? Why can't we get away with having one type of lymphocyte and not so many? The reason is because each of these cells has different action and different function in our body. The T cells are responsible for killing the virus-infected cells. They also, a subtype of them, which is called the T helper cells, they help coordinate the immune system. They are like the maestro of the orchestra that coordinate the attack against foreign bodies, albeit viruses, bacteria, cancer cells, foreign bodies. So it is our defense system coordinator. The cytotoxic T cells, they kill the viruses, infected cells immediately once the virus enter into the cell by secreting some substance that make these cells die. And of course, the virus or the bacteria inside of them will be dying as well. On the other hand, what the B cells do, they secrete what we call antibodies. These antibodies cannot enter the cell. They cannot attack the infected cell. What they do, they neutralize the viruses, and hence the viruses cannot bind into the cell, cannot penetrate the cell, and cannot cause the disease. And that's why it is important that both type of lymphocytes, the B cells and the T cells, are healthy, they work together, and they coordinate our defense immune system. The natural killer cells, which we're not talking about today because the cancers that involve these cells is very, very rare. They are the rapid response cells that kill the virally infected cell immediately after they get infected. So as I said, all of our blood cells are born in the bone marrow from a one mother cell, which is called the hematopoietic stem cell. Once these cells become T lymphocytes or destined to be T lymphocytes, they leave the bone marrow immediately. The B cells, the B lymphocytes, stay inside the bone marrow and mature, and I touched on this in detail in my previous talk. The T cells, once they leave the bone marrow, they head to a gland called the thymus. The thymus is a small gland that's present at the back of our sternum, at the top of the mediastinum, between the two lungs. It's a very important gland for the function of the T lymphocytes. Why? Because the T lymphocytes mature there. They get educated. They learn inside the thymus how to attack the abnormal cells, the virally infected cells, or the cancer cells, by a mechanism that chooses the best of the best. These cells, then they leave the thymus as educated T cells and ready to do their function. And why they are important, why we need their function? As I said, once these cells, the maestro, the T helper cell, encounters a virally infected cell, here we are, this is a pathogen, whether it's a virus or a bacteria or a foreign body, which we're all exposed to all the time, they start coordinating the immune system by sending signals to other cells, the cytotoxic T cells. These are quite effective in attacking those abnormally infected cells, secrete more enzymes and a toxic material that leads to the death of that abnormal cell with the virus inside it. So important for our health. They also, here's a microscope, an electron microscope, photograph of a T lymphocyte that is directly attacking a cancer cell. So this is a cancer cell here, an abnormal cell. The T lymphocyte has recognized this cell and it is attacking it and getting rid of these cells before they cause tumors. Sometimes, unfortunately, due to defects, which we call mutations, that affect some of the genes inside those beautiful, important T cells, they turn them into cancer cells. So what happens is that these mutations or defects lead to these cells to divide uncontrollably, causing cancer. And there are multiple types of T cell cancer, lymphoma types, that either involve the lymph nodes or the blood, which we call leukemia, or the skin. So T cell lymphoma is a common skin cancer, or one of the common cancers that affect the skin. And each one of them has different presentations, and they have different subtypes. Within the nodal T cell lymphomas, we have PTCL, AITL, etc. And I will talk about these in detail later. Sometimes these T cell lymphoma involve areas outside of the lymphatic system. Unusual and very rare. They can involve the nose, which we call a nasal type lymphoma, or the gut, which we call an enteric type lymphoma, or the liver and spleen, or a breast implant, common type of lymphoma that involves the implanted breasts. The skin subtypes, the most common subtypes is mycosis fungoides, which I will be presenting in detail next, and the leukemic subtypes, which involve the blood cells. These are extremely rare in New Zealand, so we don't see many of them. The most common subtype is called TPLL, or T prolymphocytic leukemia. Unlike B-cell lymphoma, and you can see here all of that circle, almost all of it really, there's different subtypes of B-cell lymphomas, which we are touching, and we will be talking about some of them in detail in subsequent webinars. T-cell lymphoma is rare, 4% of all the non-Hodgkin lymphomas. The most common subtypes of the T-cell lymphoma are the nodal ones. The PTCL not otherwise specified is a quarter of the patients, and then 1/5 of the patient has a subtype called angioimmunoblastic T-cell lymphomas. Skin lymphomas are less common. So let us talk about the skin lymphomas first. The most common presentation is a skin involvement in adult patients. The age of a presentation between 55 and 60. It's quite rare, with an annual incidence of 0.5 per 100,000 people, and men are more involved than women, with a ratio of almost 2:1. It usually affects part of the skin that is not sun exposed, unlike the other types of skin cancers like melanoma or squamous cell carcinoma or basal cell carcinoma of the skin. This is in the hidden part of the skin. And the most common subtype is called mycosis fungoides, which is almost 2/3 of the skin lymphoma patients. Unfortunately, the incidence of the skin lymphoma is rising. You can see here in the 70s, it was around 3 patients per 1,000,000. Now it has increased to almost 10 people per 1,000,000. And the reason is because of the increase in our ability to detect these cancers, so we became better in detecting them, but also because of all the environmental changes, the toxins that we are exposed to, and also the infectious agents that have increased the risk of these skin lymphomas. So why these lymphomas develop in the skin? What is the cause of the skin lymphoma? The cause is simply that our T lymphocytes, since they are our defense against all the toxins that our skin is exposed to, they become activated. And when they activate, they start dividing. And when they keep dividing, then the chances of them acquiring the genetic mutations or the defects or abnormalities increase, and then cancer gradually develops. So what are these irritants that make these normal, beautiful T lymphocytes divide uncontrollably and increase their risk of transforming into skin cancer? These include chronic inflammation or irritation of the skin, like chronic exposure to chemical agents, including petroleum agents or pesticides agent. Also, some skin condition, chronic skin conditions like urticaria, or psoriasis lead to the activation of these T lymphocytes and increase the risk of the person of developing these skin cancers. Of course, not every person with psoriasis develops skin cancer. There has to be other factors which are unknown to us that increase the risk of certain patients to develop these skin cancers. Some of them might be an added bacterial infection. Continuous exposure to bacterial infections, including a staphylococcus infection of the skin, may promote the activation of the T lymphocytes and the transformation to skin cancer. Viral infections, some viruses like HTLV or EBV or cytomegalovirus also lead to activation of the T lymphocytes and increases the risk of cutaneous or skin lymphomas. These viral infections, luckily, are very rare in New Zealand. They are more common in Southeast Asia. So what happens where these lymphocytes are continuously exposed to these irritants? They become cancer T cells. They acquire some genetic mutations. Some of the chromosomes that are reported to be abnormal in these cancer T cells is a chromosome 10 defect. So here we are, this normal T lymphocyte that usually protect us and help us get rid of the infection and other insults that our skin is exposed to, is transformed, unfortunately, into a cancer T cell. Then what happens? It start getting signals from some of our skin endothelial cells that line the blood vessels, that call for it to come to the skin. It's called homing of these cancer cells. So they start leaving the blood vessels and gradually penetrate because of these signals that these normal skin cells call for them to come, and they become activated and they start living under the skin, and gradually with time they start multiplying and their survival is increased and they become a tumor skin cell. And this is how these tumor cells or cancer T cells present. In the early stages, it's just a small patch on the skin, and it doesn't bother the patient. It's there, it doesn't progress, and it is in a small part of the skin, and maybe it's even missed, and patients don't see it, and it stays there for a long time undetected. But sometimes the cells start growing and increasing in size, and they become like a plaque. And in advanced stages, they become tumor-like because their size becomes so big that they penetrate the skin and become like little nodules. It is worth mentioning that there is a subtype of mycosis fungoides that is called a Sézary syndrome, SS for shortening. And this is an aggressive type of skin cancer where the cells are present in the blood, in the peripheral blood, and patients present with generalized redness of the skin due to the irritation from these abnormal T lymphocytes, which have become cancerous cells. Luckily, it's extremely rare. Mycosis fungoides is way more common than Sézary syndrome. So how can we tell if a patient is an advanced stage or an early stage? A few factors. The first one is what is the size of these plaques or skin patches? Is it less than 10% of the total body or more than 10% or covering more than 10% of the body? Are there nodules or not? And whether there are lymph nodes involvement, whether the disease had disseminated to the local lymph nodes or to other organs in the body. And again, we're lucky because most of our patients present with this patch stage where there is only irritation of the skin rather than dissemination of the disease into other parts of the body, which makes it easier to control. So how do we diagnose these tumors or these skin lymphomas? A patient notices abnormal patch or plug on their skin. It's red, it doesn't go away. They go and see their doctor, and the doctor take a skin biopsy. That skin biopsy goes to the pathologist, the histopathologist, look under the microscope, and they can tell, we can see that there are abnormal lymphocytes infiltrating underneath the skin, and make the diagnosis. The management of skin lymphoma is usually a relief of the symptoms rather than curing the disease. It usually long lasting. It doesn't progress quickly. We don't need to do anything about it unless there are symptoms from these skin patches or plugs. Most of the treatment is a skin-directed treatment, and we can treat the early stages that I just mentioned when the body is involved, or where the body is involved, and 20% of the body surface area is very suitable to give these local treatments. The other type of treatment is to give oral tablets or intravenous chemotherapy agents for advanced stages, and if the lymph nodes or other visceral organs are involved. The local treatment is quite effective, and it's usually ultraviolet treatment. It's called ultraviolet B or A or PUVA. So here it is, like a skin tanning booth. The patient goes inside that booth and receive that light, and it helps with reducing the size of the plug and reducing the symptoms. And so everyone is happy. The other modality of treatment is radiotherapy. This is a radiotherapy machine. It is very effective, skin-directed treatment, and the lymphocytes in general are very sensitive to radiotherapy. Lymphoma in general is sensitive to radiotherapy. And sometimes in advanced cases, we can give radiotherapy to the entire of the skin area and help relieve the symptoms. And in small lesions or single lesions, that can even be curative, which is extremely fortunate for these patients. Another type of treatment that's available in Waikato Hospital, and it's quite effective, it's called extracorporeal photopheresis, or ECP. It's a mouthful. You don't need to remember the name. What it simply is that a patient is hooked to a machine that takes the blood out. It's like donating blood. If you can think about it like that. So the blood leaves the body. It goes out to this machine where there is some radiation that is given with ultraviolet to be very effective and get rid of those irritating T lymphoid cells. And also an agent is given to help get rid, is called methoxylin, which helps get rid of these cells, the abnormal T cells, and then the healthy blood is given back to the body, and the patient will feel an instantaneous relief. And as you can imagine, this can be very effective in Sézary syndrome type of skin lymphoma because the abnormal cells circulate in the blood. So by removing the blood, treating it with these agents to get rid of the irritants, which is the Sézary cells in this case, and giving it back, patients feel good relief and a partial responses up to 80%, with a complete response in quarter of the patients. So it's quite an effective treatment, and we're lucky that we have access to it. Of course, in advanced cases where there are nodules, where the skin is involved more than 20%, where the local treatment becomes ineffective, we can give steroids, which can be either given onto the skin, applied locally to the skin, or in a tablet form. We have access to a drug called retinoic acid. It's usually given in advanced cases of acne that works on calming the tumor gene or the tumor cells, and it can be effective in lots of patients. We have chemotherapy agents we either give in the vein or as tablets, which we have access to. Most of them we have access to, some of them we don't. And of course, there are new targeted agents, less effective in skin lymphomas. I will talk about them in the nodal or the systemic lymphoma setting. In very, very, very rare instances in younger patients with extremely advanced disease or Sézary syndrome, we can offer what we call allogeneic bone marrow transplant. It includes giving very, very high dose chemotherapy and then rescuing the patient by giving a donor stem cells. But we rarely need to use that, and of course, not every patient tolerate allogeneic transplant. Only young patients with relapse disease who fail all the above as a last attempt of controlling the disease, we can offer allogeneic transplant. And recently, there is something really interesting that's happening. Late last year, there was this paper published in a very prestigious hematology journal called Blood. And these investigators have treated patients with skin lymphoma with high-dose antibiotics. The reason for that is what I mentioned a few slides ago, is one of the causes of skin lymphoma or contributing causes of skin lymphoma is chronic skin infection with a bacteria called Staphylococcus bacteria. And that bacteria can cause infection of the skin, especially in patients who already have some skin ulceration or who already have early stages of mycosis fungoides, and weaken the skin and causes even worsening of the symptoms, more irritation, more itching, more cancer. T cells come to the rescue and become cancer, so it worsens the cancer itself. And it's like a vicious cycle. So what these investigators did, they treated these patients with high-dose antibiotics to get rid of the bacteria that is causing the irritation and the expansion of the cancer. And they found that by treating these bacteria or eliminating these bacteria, the cancer cells or the T cells have calmed down and the cancer cells were inhibited. And this is quite spectacular. and watch the space. This is the first study. I think we need to confirm these results by doing bigger observations on more patients. So lots of these antibiotic agents have been now trialed in a wider group of patients. But we are hopeful that we might be able to incorporate antibiotic treatment as part of the treatment of mycosis fungoides very soon. The prognosis, you possibly have figured out by now that the early stages, there is no significant difference in the life expectancy of patients with early stages of mycosis fungoides or cutaneous lymphoma than that of healthy people. So you can live a normal life and expect a normal life expectancy. In more progressed cases, in disseminated cases, the life expectancy can be shortened. And unfortunately, it could be as low as 3 to 10 years, depending on how wide the dissemination of these cancer cells is. And the course of the disease is chronic. Most patients, the disease lasts for years or decades. Patients, if they die from this skin lymphoma, it will be due to local suppression of the immune system due to the drug that we give to control the disease, or secondary infections rather than the disease itself. In Sézary syndrome, on the other hand, the prognosis is poorer because these cancer cells have spread to the peripheral blood and the bloodstream, and the median survival is 2 to 4 years, with the 5-year survival of only 20% of the patients. Now we'll move to talk about the nodal or the systemic type of T-cell lymphomas, and these are the most common types that I will be talking about. The top 3: peripheral T-cell lymphoma not otherwise specified, angioimmunoblastic T-cell lymphoma, and systemic anaplastic large cell lymphoma, either ALK positive or ALK negative. And I'll shortly tell you what that ALK means. Luckily, these tumors are rare, and they comprise around 4% of all lymphomas. The most common presentation is an enlarged lymph node, and they arise from mature T cells that are present in the lymph nodes. And there is a geographic variation. They are more common in Southeast Asia, less common in Australia and New Zealand. And there are 3 aggressive subtypes, as I mentioned in the previous slides, which I will focus on. The peripheral T-cell lymphoma, not otherwise specified, is generally an aggressive disease, present in a median age of 60. The usual presentation is generalized lymph node enlargement, as well as B symptoms. B symptoms mean fevers, weight loss, night sweats. Patients feel really unwell, pains, and sometimes skin rashes. There's usually a delay in the diagnosis, unfortunately, because of the waxing and waning presentation. Sometimes a patient feels really unwell. By the time they come to hospital, they feel a bit better, and we're unable to make a diagnosis straight away. And there is a broad differential diagnosis. Sometimes it is hard because there are other differential diagnoses include infection. We have to exclude infection first. We have to exclude inflammation. But we can usually make a diagnosis based on a lymph node biopsy. The angioimmunoblastic T-cell lymphoma, AILT, is also aggressive. It presents in middle age or older patients. It has very poor outcome. And again, the presentation is either generalized lymph nodes or B symptoms, which are actually even more common than in patients with PTCL NOS. Skin rash is very common. And again, differential diagnoses include infections or autoimmune disorders or immune activation. The angioimmunoblastic large cell lymphoma, on the other hand, has a biphasic age distribution. Biphasic means we sometimes see very young patients in their 20s and 30s that present with this subtype of T cell lymphoma, and it usually carries better prognosis than the other two types. It's not very challenging to identify because we can take a part of the lymph node, look under the microscope, and see that most of these T cells have the marking, and I talked about it in my first slide, that different lymphocytes have different markings on the surface. These cells have a marker on the surface called CD30, and that group of patients carry better prognosis. As far as the ALK gene, which I mentioned a couple of slides ago, we know what causes this subtype of lymphoma, which is the ALK positive, is a translocation or a mutation or abnormality in a small gene in the lymphocytes. It's called the ALK gene. We don't know what causes the mutation itself, but we know when it is present, this subtype of patients, which we call the ALK positive T cell lymphomas, they carry good prognosis, unlike the other two subtypes of lymphomas. How do we diagnose this group of patients? These patients present with enlarged lymph nodes. Maybe they have a skin rash or tumors. They can have enlarged liver or spleen. They could have abnormal blood count. And the reason for this is because extranodal or out of the lymph nodes involvement is common, unfortunately, in this group of patients. Again, we take a biopsy, which we cut a small piece of the lymph node, or we do a bone marrow biopsy and look under the microscope to see these abnormal large lymphoid cells. These are T cells. So excisional biopsy is usually required. Then we send this sample to the pathologist again, and they do the stains. They do the CD30, which is really important, and other stains to confirm the diagnosis. The reason for that is also because some of these special stains carry prognostic value. As I mentioned, the CD30 carries better prognosis. The ALK1 cells carry better prognosis, while, for example, a mutation that's called a P53 mutation carries worse prognosis. And we also do, if some of you have heard of these tests, we call chromosomal studies or genetic studies to see if there are bad chromosomes or bad signals versus the good chromosomes, which we already mentioned, which is the 2,5 translocation in this group of patients, which carries favorable prognosis with a 5-year survival of 70%. So we do all of these tests. We look under the microscope, we do the stains, we do the genes, we do the chromosomes, and then we meet with the patient to tell them what subtype of T cell lymphoma they have. And the prognosis depend on that subtype. Unfortunately, most of the subtypes that don't carry the ALK gene have poor prognosis with a median survival of less than 2 years, while those with the ALK positive anaplastic large cell lymphoma, the survival is around 80%. And there are factors, so prognostic factors that can tell us also if some of you had lymphoma in the past and met with their hematologist. Your hematologist might have mentioned something that's called the IPI, or the prognostic score. And these are some parameters that can tell us whether a patient will do better. One patient would do better than other patients. The mostly common use is called the IPI score, and you look at the age of the person. If they are older than 60, they do carry a worse outcome. If their tumor marker, which is called the LDH, is high, which means that the cells are dividing quite fast, that's a negative prognostic marker. If they are really weak and bedridden versus those who come to my clinic room walking through the door and feeling good about themselves and do all of their daily chores normally, they do better. Those with advanced stages, if their bone marrow is involved, if the liver, the spleen is involved, they do worse than other patients. There is another score which looks at the bone marrow involvement, and generally I counted here as an extranodal involvement or as an advanced stage. So I usually use the IPI score. And the reason why the IPI score is important is this. Patients with T-cell lymphoma who have very few risk factors, 0 to 1, they live longer than patients who have 4 to 5 negative factors. So based on the IPI score and based on the subtype of the T-cell lymphoma, I can generally tell the patient when I see them how well they will do and what is their expected overall survival in months or years. General guidelines for a treatment of these lymphoma, it's usually chemotherapy. If the stage is early, we might be able to get away with 4 cycles of chemotherapy, short course of chemotherapy, plus radiotherapy. In an advanced stage or high-risk group, I give 6 cycles of chemotherapy, plus minus radiotherapy, depending on the response to the chemotherapy and whether patients achieve full response or not. In younger patients who have good performance status and younger than the age of 60, we usually offer consolidation with high-dose therapy and what we call autologous transplant. Autologous transplant is giving the patient their own stem cells, which is usually better tolerated than the allogeneic transplant, which is giving the patient another person stem cells. And this is a study that looked at transplanting high-risk patient, the ALK negative patient, and the PTCL not otherwise specified patients with their own stem cells after the chemotherapy. And you can see that they achieved better survival if we consolidate the chemotherapy with high-dose therapy and autologous transplant. Of course, I have to emphasize that this group of patients will have to be less than the age of 60 to 70. We can go up to the age of 70 if the patients have good performance status, and especially in the group who are the ALK negative anaplastic large cell lymphoma, the 5-year survival was 70%, which is pretty good. The problem arises when the disease comes back, because usually when the disease comes back, our options are limited, and the options that we offer the patients are restricted based on the patient age, performance status, whether they have other medical problems, whether they are transplant, allogeneic transplant or not. And it's always a balance. There's always that balance between treating a patient and trying to achieve a reasonable remission versus treating a patient and causing more toxicity and more problems. And I don't want to make my patient sick for just the sake of giving them a treatment. There is the balance. The treatment has always to be given to achieve a better performance status, to make the patient's life better, and also to prolong their survival if we can. In younger patients, as I said, those younger than the age of 70 with no comorbidities or 60, then an allogeneic transplant would possibly be my first-line treatment in the relapse setting. Of course, I have to put them in remission again. So if they are chemosensitive, they do better. Their progression-free survival, their disease-free time or chance is 50% versus those who relapse and then don't respond to the second-line treatment. Those who have had multiple lines of treatment in the past do worse than those who have had only one line in the past. So even in the younger patients, even in those who are suitable candidates for an allogeneic transplant, there are multiple factors that will play into my decision whether to proceed to an allogeneic transplant or not, which is including how many lines of treatment they had and what their sensitivity to the second-line chemotherapy treatment is. What is encouraging is the emergence of a new novel treatment or targeted therapy, a treatment that have been tried all around the world and have shown to be effective in some of the systemic T-cell lymphoma patients in the relapse setting. They are not available here in New Zealand at the moment. There are ongoing trials all around the world, so watch the space, and I'm hoping that in the near future we might have access to some of these drugs to patients in the relapse setting who have T-cell lymphoma. One of these drugs is called romidepsin. I will talk about it next. It represses the DNA of the cancer cells and inhibit some proteins in the cancer cells, which leads to its death. Its approval in the United States in the relapse setting is based on a trial that enrolled 131 patients and showed that the response rate was 25%. This is again a relapse group of patients with T-cell lymphoma. And the complete response was 15%. And some of these responses lasted for more than 2 years. This is extremely, extremely encouraging. So we are watching further data extremely eagerly. And we hope to be able to have access to romidepsin in the future. The other drug is called the pralatrexate. It is similar to methotrexate. Some of you might have heard about methotrexate or had it in the past, but it is more advanced and more specific. This study enrolled patients with a relapse setting again, 32 patients. 1/3 of them achieved response, and the duration of response was up to 10 or a median of 10 months. So that's encouraging as well. The third drug or targeted drug that I want to talk about is called the brentuximab vedotin. I mentioned to you that some of the T cells, especially the anaplastic T cell lymphoma subtype, they carry a marker on the surface of the cell. It's called CD30 or an antigen. That this is the name of the antigen. It's CD30. So what we have here is a designed drug, just like the rituximab, which is targeting the CD20 on the B lymphocytes. This is a brentuximab, which targets the CD30 on the T cells. And inside it, there is a toxin, a powerful toxin. It's called MMAE. It's an agent that once it enters the cell, it leads to the disruption of the tubules and the DNA and kills the cell. So the cell dies, apoptosis. It's a very powerful drug. In 2012, Barbara Pro and her colleagues published this very encouraging study in the Journal of Clinical Oncology. They use this drug in patients who have CD30, because you have to have the marking around the tumor cell for this drug to be effective. They used it in the CD30 anaplastic large cell lymphoma patient and showed that the overall survival was prolonged in this group of patients. And patients took around 58 patients took around 12 months to progress or relapse. So that led to this trial, which was published last year in the Lancet Oncology Journal, a groundbreaking trial, randomized study, which used this drug, brentuximab, the anti-CD30, in a CD30 expressing patients with T cell lymphoma. Instead of CHOP, they gave CHOP with brentuximab in the first setting. And you can see from the graphs that the patients who received brentuximab upfront have done better than those who received the CHOP, which is our first line treatment, with a median time to the disease progression of 48 months versus 20 months in the disease in the CHOP group, and a significant p-value. And even the survival of the patients, despite it was excellent in the CHOP group, but you can see the survival of this group of patients is better. So we are very excited about this study, and it will have implications in our practice. We are hoping this is the first time that these new type of treatment, the targeted treatment, are incorporated in the first line setting in the treatment of T cell lymphomas. So this is a groundbreaking research. this is the last slide. We've taken an hour now, it's 1 o'clock. So we will end with summarizing that T-cell lymphoma is a rare cancer of the lymphatic system. It can affect the skin, the lymph nodes, or other organs in the body. The skin subtype carry good prognosis because it's slow growing and we have effective local treatment. Unfortunately, the nodal type is usually present late, carries poor prognosis and need intensive systemic or intravenous treatment. There is hope for these groups of patients because of the emerging targeted treatment, which are extremely promising. And we're all excited and watching the news, and hopefully we'll be able to incorporate it for our patients here in New Zealand in the near future. Thank you very much.
Thank you, Summer. That was a fantastic talk and so thoroughly detailed, and I think, yeah, just an incredible resource for a group of patients who, yeah, do have a pretty rare condition. So thank you so much.
It's my pleasure. Thank you, Natasha. We can answer a few questions if there are any.
Awesome, thank you. We are coming up on our time, so I thought maybe we'd go through a few if that's all right.
Sure.
So I'll just read these out as we go. So our first question is, thank you for the informative presentation, especially about MF. Understanding it more now, and I appreciate knowing more about its management and treatment. So I think that's a thank you. So
you're most welcome. I'm glad that you found it useful.
And we've got our next one here. So how significant or common is the link between bacterial skin infections and the development of cutaneous T-cell lymphoma? Does the risk increase with the extent of a chronic condition or if the infection is untreated?
Both, really. So if you have a chronic exposure to these bacterial infections in the skin and they are not treated, that can lead to continuous stimulation, as we showed, of the T lymphocytes, which is our defense system against these bacteria. And the chances of these cells, if they keep dividing, of them acquiring some genetic mutations and turn into a cancer cell is higher than if the skin condition or the skin infection is treated. By saying that, not every patient with chronic skin infection develops T-cell lymphoma. We don't know exactly what happens, but we know that lymphoma or cancer in general needs more than one hit, needs more than one factor. It's a multiple hit or mutations that has to happen inside the cell to make it transform into a cancer cell. But one of these hits is certainly a chronic infection or chronic stimulation of the skin by exposure to irritants or other skin conditions like psoriasis. You know, the more chronic the infection, the more risk the cells will transform to cancer. The more widespread the infection, the more the risk. But who will develop it and who will not, we don't know. But I highly recommend that if there is this chronic skin condition or chronic infection of the skin, is treated as soon as possible to reduce the risk of transformation to lymphoma.
Great to keep in mind, thank you. So we've got another one here. How many patients have AILT in New Zealand?
It's very rare. In my practice, I possibly see 1 to 2 patients a year. So I think at a given time, there might be 10 patients max in New Zealand. We have a big lymphoma center at Middlemore. So angioimmunoplastic T-cell lymphoma, luckily, is extremely rare. And we only see few patients a year with this subtype.
Yeah, it's extremely rare. Thanks for that. So our next question here, is there any research underway to further understand the causes of, e.g. MF or T-cell cutaneous lymphomas in general?
Yes, and the paper that I showed with the staphylococcus antibiotic treatment that led to the patients achieving remission for T-cell lymphoma is extremely important paper because the more we look into it, the more our understanding deepen with regard to the complex interactions that happen in our skins, and the signals that I showed you a slide of, the homing of the signals that these T cells receive from our endothelial cells, the lining of our blood vessels to call it to come to the skin and multiply and form the tumor. So the more we look into these interaction, the better our understandings become, and the easier for us to design the treatment that to break these cycles, break these interaction, and that's what we call targeted treatment. So I personally believe that the future belongs to these target treatment rather than treating patients undifferentiated with chemotherapy, radiotherapy, other topical or systemic agents for skin lymphoma. We just look at what is happening and the interactions that are happening between the different cells and the signals and block these signals. So certainly there is lots of research is happening at the moment.
Awesome, thank you. And for that, the person who asked that question, this video will be on YouTube, so you'll be able to go back and find that resource as well, maybe search it up when you have time.
Yeah, I put all the resources at the bottom of the slides. So if you're interested, you can basically just, type the name of the paper or the resource into your search engine and you'll be able to access it.
Thank you. And you have a thank you here as well for that. So I'd say this is maybe our last question here. So how often are cutaneous T-cell lymphomas and other lymphomas picked up by dermatologists as opposed to a GP?
Right. We were talking, Natasha and I, about it before we started the webinar. And I was hoping that some of the cutaneous lymphoma patients will be logging on because it is really hard for these tumors or lymphomas to be diagnosed by the GP. They could mimic a skin reaction. They could mimic an allergic reaction or, like a small patch of urticaria. I think it is important that these abnormal skin patches are checked by a dermatologist, and most of the patients I share their care with my dermatology colleagues because they are the right people to make the diagnosis. Having said that, most of our GP colleagues are able to take a skin biopsy, what we call a punch biopsy. So if you have an abnormal skin lesion, I highly recommend that the first port of call, and so to speak, is the GP. They check it by taking a small punch biopsy, send it to the lab, and if a diagnosis of T-cell lymphoma is made, then they refer you to a dermatologist who will talk to us in the hematology department, and we will coordinate your treatment if needed to. Remember, not every T-cell lymphoma, cutaneous T-cell lymphoma needs to be treated immediately. If it is a small patch, we can just, and it's not causing any problems, we can just observe it and wait. But on the other hand, we also have very effective treatment, which are the local therapy, the PUVA and the local ointments to treat it effectively. And it shouldn't affect your survival if it is in the early stages.
Awesome, thank you. I think that's all of our questions for today. So just to kind of close things up, I just wanted to say thank you so much, and thanks everybody for coming on and joining us on our winter spring webinar series for today. Summer, thank you for an incredibly informative and thorough talk on T-cell lymphoma. This will be a great resource for patients out there now and in the near future, and maybe for years to come as well. So thank you.
No problem. It's my pleasure. It's my absolute pleasure, Natasha. And thanks for inviting me to talk.
It's our pleasure, honestly. We do appreciate it. And just for everyone out there who's watching, this is not our last lymphoma talk that we'll be having during this series. So do have a look on our website if you'd like to register for any more of the exciting talks we have to come. We'll also have this talk available on YouTube in the coming days, so you'll be able to revisit it there. And yeah, just a big thank you to everyone for tuning in for today's webinar, and we hope to see you again maybe on another session in the very near future. Awesome.
Thank you, everyone. Bye, Natasha.
Thanks, Summer. See ya. Bye.
See you. Bye.